Thanksgiving break.
Okay, they're getting snacks, that's fine, but they're gonna miss that contact.
I parked right next to you. Yeah, because nobody has my
It looks like great today.
So today we're talking about general anxiety disorder and panic disorder. We're also going to be talking about PTSD and obsessive compulsive disorder. We've had 3 PowerPoints to review prior to coming to class. Yes?
Yes.
Everybody has them?
Yes. Yes.
Beautiful. It's a 2.5-hour class, so how many questions do you think will be on exam 5? 20? 9 to 11? 10 to 12. Significant amount of questions. Okay? Professor Pepco-Leach will be talking to you on Monday about this. These are all under the general anxiety disorder, right? Professor Pepco-Leach is going to talk to you on Monday about social anxiety. She's also going to be talking to you about the personality disorders. We added the personality disorders in two clusters, right? We had to fit it in this semester because they were less than CCNP, right? And we want you to have it as part of your mental health and illness material. Class activity will be at the end. I'm going to have a lot of time for it, so I might be going a little bit quicker through some of the slides. But if you have questions, please let me know, right? Because you reviewed it prior, is it correct? Yes. Good. But I really want to get to a class activity. It's going to be fun. I'm so excited. So the learning objectives are listed here. I'm not going to read those to you. And here's your CNP concept map, which talks about how anxiety is interrelated with some sub-concepts and the circular concepts as well. So anxiety, what is it? It is a response arising from the anticipation of perceived or actual threat to self or significant relationships. Okay? Clinical manifestations are listed here. There's a feeling of uneasiness, apprehension, dread, feeling of unhappiness. Anxiety and depression are married. So there's a feeling of, you do have those depressive symptoms. Feeling of distress in everyday situations. Some of the physical features are fatigue, headache, muscle tension. Headaches are on there twice. Digestive issues, irritability, and feeling out of breath or some hot flashes. Now, we want to think about that for lifespan considerations, because hot flashes are exactly what I experience right now, right? But it's not necessarily. You want to think about the physical features of anxiety, the physical features that the patient is experiencing with anxiety, okay? Why? Why do you want to think about these physical features?
Because some people mimic other.
Absolutely, right? Irritability, tachycardia, those kind of things. Patient could be having a heart attack. So we never ever want to dismiss physical features of anxiety.
And is that what brings you to the doctor in the first place?
Sometimes, right? You might be having a physical thing, but if there's a comorbidity, I say that word a lot, but a lot of the mental health, the mental illnesses have comorbidities with physical stuff. So you always work them up. Okay? Unless what? Always, there might be a minor workup, but unless what? There's a history, right? Patient presents a history of anxiety, then you're thinking more along the lines of the anxiety, but you're still going to do the workup for the troponin and all those things that you need to do. Make sense? The diagnosis of excessive anxiety is about everyday problems for at least 6 months. So you need to be experiencing these things. So everything in the DSM-5 has a time frame. So this has been going on for 6 months. It's not just the normal, I say normal anxiety. We all have stressors, right? And sometimes respond with some of the symptoms of anxiety. It's not just a here or there kind of thing. Okay? It's been going on for a bit. Principal sign is intense worry over a long period of time. GAD, you'll also see general anxiety disorder written as GAD. Anxiety is more intense than the situation requires. What does that mean? The symptoms of anxiety is more intense than the situation requires. What does that mean?
It's like
Feel like it's worse.
Overreacting, right? So your coffee maker breaks, right? And you're like, well, I know coffee's important. First thing to but I'm just saying, your coffee maker breaks in the morning. You're trying to get out the door. You want your coffee, right? Instead of thinking, oh, I have this extra time, and if a quote's right, you start flipping out. You're like throwing things, like it's an overreaction to the stimulus that's going on. Okay? Days are filled with tension and worry, even though there's no external stressor. So you may not even have an external stressor present, but you're constantly worried, thinking about what could be, what's happening. Okay? Anticipated disaster coming. You're preoccupied with your health issues, money, familial problems, and work challenges. Key symptoms are fatigue, muscle tension, irritability, inability to concentrate. Digestive issues are common. Fatigue is in there twice, so that's probably a good one, right? And restlessness, hot flashes, feeling short of breath, and difficulty with sleep. Greater in women than men. Higher numbers in women than men. Panic disorder is a whole different beast, even compared to severe anxiety, right? Panic disorder is constant sudden attacks of terror, sometimes accompanied by a pounding heart, sweating, fainting, or dizziness. It's recurrent and unexpected, not due to the use of any substances. Panic disorders are not accounted for by other disorders. So by that I mean you look at your DSM-5 and they don't have that criteria, right? Alcohol use, any of those things going on, right? Safety is huge when someone's having a panic attack. What are you going to do? Let's talk about that. Because a lot of times people who have panic attacks might need to be hospitalized, right? So you have someone that comes into the hospital and has a panic attack. What are you going to do? How are you going to respond to that as a nurse? Absolutely. And then Ativan. We use the benzodiazepines, right? But how are you going to get the Ativan in is key, right? You got it. You got it. What deep breathing? What else are you going to do? Therapeutic communication. What do you mean by that? Be soothing, be calming. Use your tone of voice. Nice and easy. Nice and slow. Be concise in what you're telling someone who's having a panic attack. Give direction. Come with me over here. We're going to go into somewhere there's not a lot of stimulation. They don't need stimulation. They're already stimulated enough, right? Come over here. Let's do this. You want to do those kind of things. Be very clear. Get that med in. It's that you need to medicate for panic attacks, right? They need some kind of medication. How that happens is all up to how you, because they can't concentrate. They're totally not understanding what's going on in the situation. Be like, what's happening, right? So how you advise them can very well determine how you're going to get the Ativan, you're going to get the benzodiazepine, right? So be thinking about that when someone's really having severe anxiety or a panic attack.
So the difference between panic and anxiety is the heart palpitations?
The physical symptoms, yeah, and I'm going to show you the video because I had some technical help this morning, so hopefully you'll go. And if not, just bear with me. I'm still working with the technical stuff. Yeah, it's the absolute extreme that it's all those physical features. They cannot in anxiety you might be able to concentrate a little bit, you might be, but they're in another world really. Okay. We're going to look into videos. The first one might be a little bit disturbing to you. I'm just warning you. And then the second one is Leonard's panic attack. I want to be clear. that I know, Leonard's panic attack has some funny things about it, but when you experience someone who is, when you are working with someone who is having a panic attack, there's nothing funny about it. It's quite scary. Okay. All right, let's see. Okay, the first one is anxiety. It's just anxiety in general. Oh, it's not fair though. Why? What do I have to do? Swapping in between. Ooh, there it is right there. I know. Here we go. Oh, here. You're right. Okay. But it's not coming up. Just hang on for 1 second. Here, Jane, technology guru.
I can't just say it. That's a shitty story, but
I'm happy for you.
Oh, there we go. So we're there. I want that. Okay. All right. I'm just going to do that. Because I don't want to have to get all right, you guys ready? Yes. This is general anxiety one, okay, where's my mind? You're right. There's no volume. Video's not my thing, right?
Just I've never said anything.
I know. You can like feel like why is it not? Right? Just sitting in the
No, what they had to talk to her. I think they went over there and agreed. Because I definitely didn't. I ain't wrong. I tried to eat wrong. It's not a big deal, but
Hang on, guys.
they could have given that to her though. They could have. I would have. At least somebody did a good job for that.
Yeah, we went all the way.
It's 1 point, y'all. Stop. It's only 1 point, guys.
Yeah, but it's cool. Are you staying or are you going? Oh, he's coming. Yeah, maybe it's scary. And I had that $1 million. It's gonna be great.
I'm giving you.
Oh, they're married though. Right? I want to go away so quick, I feel like. I can't wait, I just want to know you. I know, that's what I don't even ask people, like, you want to be? That's a good question.
I'm just like, I'm just like rush. There's a bunch that I want to get done.
first ever, like, the idea of planning a wedding, like, makes
Oh, nice. It's so boring. No, it's like, no, it's just like three worksheets with forever. I go through that. It's like episode.
There you go.
I'm perfect. So, my friends are getting married in the summer. Like, they have a big wedding. I know. We thought it was going to be quick to go through, and then it was like 3 hours. Yeah.
I went to a wedding, and it's like, it was the same thing. They got married during the pandemic, and then did like a big wedding. They like had a ceremony. We timed it. It was 4 minutes and 30 seconds. The ceremony. All they did was exchange a few vows, and they were like, "All right, time to marry." That's it.
These are embedded in your PowerPoints, okay? So I just want you to see what she's doing. Take a listen to, take a look at what she's doing and take out all the signs and symptoms of anxiety while you're watching it, okay? I'm going to be talking as well, okay?
Is she a nursing student, do we know?
Well, you know what, and here's the deal, and you guys have a lot of anxiety, and we're well aware of that, right? No, I'm not kidding, and sometimes I even have Sam Johnson come into this classroom and Terry Littella come into this classroom to talk to you, and it's late in the game, but to talk, and I've had them go to the, the open house in the past, because there are services here for people who deal with anxiety, right? There's services here that you can get counseling. They have all these different things. They have a lot of integrative therapy things going down at the Danbury campus. And you might say, oh, geez, I don't have time for yoga. I don't have to, Professor Anderson, right? But if you don't take care of yourself and take care of your anxiety, your test anxiety as well, you're not going to make it. So you're worth it. You're worth the time. Okay? So think about the counseling services that are available at the school. All right. So now the goal for this is to point out, because we don't have any audio, right? But point out if you go home and listen to this video, you will hear her. Her speech gets really rapid. She gets very anxious. The speech is like really, really fast, right? So this is what it's like, and there's no visible signs. People don't understand what anxiety does to a person. They don't get it because there's no physical, not a lot of physical signs. Some people have it together, right? People have it together and they deal with their anxiety. They take their medications, whatever. But no one knows, right? So look at the physical things here in this video.
I can put the captions on. Oh, yeah.
Okay. Thank you, James.
Something.
Wait, can somebody play it? Like on her thing and just play it on the microphone?
James, to the rescue. You are good, James. Thank you. From the outside, it's easy to figure out somebody because her hair is curled and my cheeks are internally flushed, and I don't have a care in the world except for my demons. To be worn like a scarlet letter pin on my chest. And they assume if I can't see them, you can't see them.
Maybe the tab is muted. On the top. Like on the top?
Oh, yeah.
Oh.
No, it is. It is.
What?
Right there.
Up there.
Okay.
Nobody likes to talk about the tough stuff. Hell, I don't like to talk about the tough stuff. From the outside, it's easy to think that somebody's got it all figured out. Because my hair is curled and my cheeks are intentionally flushed, I must not have a care in the world. As if it were expected for my demons to be worn like a scarlet letter pinned to my chest. And they assume if you cannot see it, then it's not really there. As if pain does not exist unless you're bleeding or slung in a cast or staggering with a limp. But sometimes the most painful demons are the ones they can't even see. So we learn how to smile, how to grin and bear it, because nobody likes to talk about the tough stuff. Hell, I don't like to talk about the tough stuff. I have anxiety. It feels like every cell in my body is moving so fast that my veins are blurry. That despite the constant metronome of my heartbeat inside my ears, it's like listening to a spastic drum line. It feels like bees in my ears, like a broken white noise machine playing all of the sounds at once. And I don't even realize I'm gritting my teeth or cracking my knuckles or rubbing my forefinger against my pinky or twisting the gold band on my middle finger, holding on to myself like I'm the only lifeline bridging the gap between reality on my own 2 feet and the atomically loud abyss of noises and sounds and feelings of fleeting rushing through my veins. And I'm avoiding eye contact. Not because I'm not listening to what you're saying, because I'm listening to the sound of my own voice, hoping that through your ears you can't hear that it's 2 octaves too high and on the verge of breaking because my palms are sweating and I somehow forgot to speak with anything behind my words other than insecurity. My anxiety feels like fire, unexplainably hot and rash and frustrating as I gnaw the inside of my cheek as if the solution to this feeling is buried between my teeth and gums. It feels like drowning, but it feels like burning, and it feels like fucking forever. I imagine my feet moving with trails of dust behind them like those cartoons because somehow it feels like I'm moving faster than the 60 seconds they've allowed in a minute. All the while, I'm just playing catch up on the stopwatch. And it doesn't add up like it did in high school mathematics. I can't carry the 1 and find the square root of the problem because most of the time, there is no problem. There's no life or death situation. There's no rhyme or reason. There is just feelings, and I'm feeling all of them at once. Some days are better than others. Some days are worse. But they're just days. And I've got more where they came from.
What things did she say that we just discussed? What symptoms did she display that we just discussed? Rapid what? Rapid speaking, what else? Palpitations, what else?
Trying to hide it in so that way nobody
Trying to hide it.
knows what she's feeling.
What's that?
I said trying to hide it in so the other people that she's speaking to doesn't know how she's
So
feeling.
other people don't understand, and that must be tough, right? Because they need help just like anybody else, right? People who have anxiety need help just like anybody else. So you're trying, so it's all covert in a sense, right? Yes.
She always felt like she was trying to catch up.
Always felt like she was trying to catch up.
Like a panic.
What else?
On what other people are saying.
What's that?
Can't concentrate.
Can't concentrate on what other people are saying, and that's more of a, and we're gonna go through the various levels, but that's more of a, like, severe anxiety, right? Panic mode. Do you have something, Nicole?
She's feeling worried when she's doing that.
Worried, that's a key factor in anxiety. Worried, but she reckons, like, she doesn't, there's nothing there, right? So when she goes back and looks at the anxiety, it really wasn't like along the lines of the coffee maker example, right? There's not, or the amount of anxiety doesn't match what the problem, the stressor of the problem is. So that's a key factor, and she said that in the video. Okay, now I'm going to show you the, now that I have my technical gurus on board, I'm going to show you the Big Bang Theory. And again, the Big Bang is funny, but there's also some physical features and different things going on here, okay? How come there's no microphone up there? Okay, let's see if this,
How do I look?
Could you be more specific?
Can you tell I'm perspiring a little?
No. The dark crescent-shaped patterns under your arms conceal it nicely. What time is your date?
6:30.
Perfect. That gives you 2 hours and 15 minutes for that dense molecular cloud of Aramis to dissipate.
Is it too much?
Not if you're a rugby team.
By the way, if it should ever come up, you didn't join us because you stuffed yourself with a chicken carbonara sub at Quiznos.
Why would I join you?
No reason. Oh, you know what? Maybe this isn't such a good idea.
Oh, no. Well, now, there's always the possibility that alcohol and poor judgment on her part might lead to a nice romantic evening.
You're right. Alcohol, poor judgment. It could go well.
Of course, there's the other possibility that this date kicks off rather unpleasant 6 months of the two of you passing awkwardly in the hall until one of you breaks down and moves to another zip code.
You could have stopped it. It could go well.
If I could have, I would have.
I'm a perfectly nice guy. There's no reason we couldn't go to the restaurant and have a lovely dinner. Maybe take a walk afterwards. Talk about things we have in common. You love pottery? I love pottery. You know, there's a pause. We both know what's happening. I lean in, we kiss. It's a little tentative at first, but then I realize she's kissing me back, and she's biting my lower lip. You know, she wants me. This thing is going the distance. We're gonna have sex. Oh God! Oh my God!
Is the sex starting now?
I'm having a panic attack.
Oh, okay. Well then, calm down.
Calm down. I wouldn't be having a panic attack. That's why they call it a panic attack.
All right. Would you just sit down? Yeah, sit down now. Close your eyes.
Why?
Just do it.
Okay.
Now, try to increase your alpha wave activity.
What?
It's a biofeedback technique. It's relaxation through brainwave manipulation. I read a paper about it in Journal of American Neuroscience. It was a little sparsely sourced, but I think basic science is valid. I probably have it here somewhere.
I can't go through with this. You need to call her and cancel.
Me?
Yes.
What should I tell
I
her?
don't know. Tell her I'm sick.
Okay.
Not the kind of illness that will make her want to come over and take care of me, but nothing so critical that she'll feel uncomfortable going out with me in the future if I want to try this again.
Got it. So I'm assuming nothing venereal. I'll just tell her that you had a routine colonoscopy and haven't quite bounced back.
Give me the phone.
I thought you wanted to cancel.
I can't because if I don't show up, she'll still be expecting you.
Why would she be expecting me?
Stop asking me all these questions. I need to take another shower.
Okay, so what kind of symptoms did Leonard have?
Sweaty.
Sweating. What else? He's jittery, yeah. What else?
Overthinking.
Overthinking, what else? Extreme fear of what could happen, right? And is it likely that those things are going to happen? No. So we had extreme fear. Well, I like this video because it kind of gets to how not to behave when you have someone who has a panic attack. What kind of things did Sheldon do that was wrong? Do not tell my husband cornered me once and said to calm down. And I'm like, do not tell me to calm down. I'm like, I'm in the corner and you're telling me to calm down? Like he's not, rough in any way.
You're not having a panic attack.
Correct. We were having an argument and he was like, calm down. And I'm like, don't say calm down to anybody, ever.
It's never worked.
It's not successful, right? Because if you could, and he was very good about it. He said, if I could calm down, I would be doing it, right? He understands, right? What else did Sheldon do that was not a good thing when someone's having a panic attack?
He wasn't clear and concise.
He wasn't clear and concise. He started going into the biofeedback business, right? And talking about himself. It's not nothing to do with what it's not about us. I say that so many times about nursing, but it isn't, right? It's about the person who's experiencing the attack. You did a few things that were really wrong. Opposite of what we're trying to have you do when the situation happens. Okay? So some risk factors are a shy child, stress or a chaotic environment, neglected use, trauma, loss of parent, sibling, all those traumatic events. Social factors is limited socialization or absent altogether. Life-threatening environments. And genetics plays a key role, right? 40% of patients with GAD have a family member that's a close family member with a disorder. Diagnostic test. Make sure you do a complete H&P. There is no diagnostic test to diagnose anxiety disorders. There's no real diagnostic test for most of the mental illnesses, right? So you have to follow through on signs and symptoms. Make sure that you use all the diagnostic tools. If they're having the signs and symptoms of an MI, you're going to do troponins, right? An EKG. If they're having GI symptoms, which is very common in anxiety disorders, you're going to do an abdominal ultrasound, maybe CAT scan, the liver, all the abdominal organs, right? CBC, lights, wide stools, those kind of things. The diagnosis is made according to the symptoms, and if they interfere with a person's daily life, okay? And so I'm going to do according to the DSM-5 criteria. Pharmacological therapy, your favorite part.
How did you know?
It's important. It does control symptoms. But the patient also needs psychotherapy. You're not just throwing meds at them, right? They need psychotherapy in order to deal with anxiety and panic disorders. So the benzodiazepines, where'd you see those? Alcohol use disorders, so we use them here as well, right? They're used to treat patients who have severe anxiety or panic level anxiety. Short-term use because the benzos are habit forming. So you want to make sure there's short-term use of them, okay? And they need to be tapered once you want to discontinue. You need to make sure that you're tapering them. And here's a list of what you guys know from the alcohol use disorders: Xanax, Valium, Ativan, and Librium. Buspar is a newer medication, and I've seen it used in the hospital quite a bit. There's no risk of dependence with Buspar, so that's why sometimes we go to that medication instead. And the side effects are nausea, headache, and dizziness. And the patient needs to consistently take it for 2 weeks for anti-anxiety effect to work. I had someone that came in with GI symptoms. We were taking care of them, and they ordered Buspar PRN, and I'm like, what are you doing? Like, we got to give this regularly, right? If you're going to start it here, we know that we need to give this regularly, right, for it to work.
But they were there for GI, please?
GI symptoms. It was a younger person with GI symptoms. Again, we're working them up for the GI symptoms because it's their first admission, and you work up for GI symptoms for physical symptoms anyway. Okay, and then we rule them out we rule out the physical, and then we go to the DSM-5 for criteria. Good question. Any other questions? We will use the antidepressants as well. Anxiety and depression are married. The antidepressants work. The SSRIs need to be taken for a few weeks to be effective. So you just don't take these meds and then all of a sudden your anxiety is gone. Or your panic attacks are gone. Generally started at low dose and then adjusted according to effectiveness. You're looking at nausea, agitation, and sexual dysfunction. That is a side effect of a lot of the psychotic meds used to control mental illness that needs to be discussed with your patients. Because that's the reason sometimes we'll stop taking their meds for mental illness, right? Sexual dysfunction. And there are other avenues to explore as far as that goes. Yes?
Are these the medications that people kind of don't feel as much? You know how sometimes it kind of levels them out where they don't feel other emotions as well?
Correct.
So is that?
Yeah,
Okay.
yeah. And that's another problem because they're like, oh, I'm not feeling, like there's, anxiety is protective, so that it, you know, it will, and it's a protective response, right? So once you're like, you kind of get used to that. Once you're in a couple weeks, you have that feeling where like you're not yet feeling emotions, right? And it's like, well, what about this? So that's where we say start low and go slow, because we don't want to go to that other end of it. We just want to be able to control symptoms. Okay. Good question. So there's a list of the antidepressants there. The MAOIs, they're the last line of resort. You guys talked about MAOIs in your first level. What's the problem with MAOIs? Why? Because there's so many side effects, right? What happens with why do we get these, a lot of times get these side effects from the MAOIs? Serotonin levels, right? You can run into serotonin syndrome, right? Why? How? What happens? There's a lot of food interactions, a lot of drug interactions. What kind of foods do we want to watch out for from the MAOI? Tyramine, right? That increases your level of tyramine. That'll increase your level of tyramine. What kind of foods have tyramine in it?
Aged meats.
Aged meats. What else? Cheeses. What else? Wine. Beer. Most alcohols, right? What else? Any processed foods, pickles, stuff, right? So you want to be very careful if they wind up going on this last line of MAOIs. You know, because it can, and what's the response? What's the response? Serotonin syndrome or hypertensive crisis, right? So you're looking for those symptoms. And then you're you're giving them a list, right? Of the food so that they know, patients know. Questions? We also use Inderal for some physical symptoms like flushing and hyperventilation. So it's an off-label use, but we use Inderal as well, or propranolol. Questions about the pharmacology? This slide. Yes?
So the propranolol, is that supposed to be taken consistently, or I know it's a beta blocker.
Usually for symptoms.
So consistent or like just as needed?
As needed.
Oh,
Yeah.
So it's in addition to these
You
other
can,
meds?
they can be ordered in addition to if the patient is experiencing like severe.
Okay. Would it ever be like a standalone?
What's that?
Would it ever be like just a standalone? Like we would give you this just because?
No.
Okay.
No. That's a good
For
question.
this.
That's an excellent question.
Okay.
Yeah, no, it's not. The propranolol is not a standalone medication. That's just to control those symptoms. You have the SSRIs or the benzos. Okay? Short-term use of benzodiazepines. Good question. Thank you for. So the non-pharmacological management is cognitive behavioral therapy for most mental illnesses. What is that? Can you guys tell me what that is? CBT?
It's basically learning how to like, what's your triggers, how you react to them, and then foreseeing what you want your next interaction to be. Like, if it happens again, how do you want to react to it?
Thank you. It is reflection in a sense, but it's psychotherapy, right? So it's based on the thought process that you are what you think. Okay? So your cognition, what you're thinking, is reviewed. So the triggers and those kind of things, you're reviewing that. But then you're looking at ways to change the behavior. In addition. Make sense? Questions? Used commonly, CBT is used commonly for most of the mental illnesses. Herbal presentations, what kind of herbs do we use that are calming? Considered calming herbs.
Lavender.
Is that? Chamomile teas, right? Kava's a good one. But it also has some medications, right?
You're both very
Dr. Who?
Let me say it.
Oh, what did she have to say about kava?
Oh, yeah, the
It is major. What is it? You got any kind of pepper? Liver toxicity is huge, but it could be a complication of CABA. So you want to be mindful of that. Okay? Do we use anything else?
Marijuana.
Marijuana is used sometimes. Cannabis is not a bad medication. It's a medication, right? I teach cancer as well, and I said, ooh, we gave them cannabis for nausea and vomiting, and I go, it's a great drug, and the whole class laughed, right? But it's a drug, right? And it might be prescribed medically for anxiety. Good. What else? Anything else? Yes?
Ashwagandha.
Oh,
yeah. I have no idea what that is. What is it? Is this funny? Am I going to be like, are you ready for me up here? Okay. No, I don't want to think of anxiety. You know that.
It's like I was prescribed it because my doctor was like, I don't like taking like medications. And it's something like with the pharma medications you can't stop abruptly, but that you can.
Okay. What's the name of the medication?
Ashwagandha.
Ashwagandha? Ashwagandha.
They sell it in Costco now.
It's marketed as like an anti-anxiety, anti-stress, but it helps a lot.
Excellent. Thank you for that. Magnesium, yes, sometimes magnesium. Magnesium is also good for sleep, which is a problem with anxiety, right? So magnesium, what other herbal? The thing here that I want you to know is they have indications. So herbs have indications. And I know Dr. George talked about that as well.
So it helps you like
Right? But there are indications. What about lavender? Is lavender calming? Lavender as well. St. John's wort as well. That's also some indication. You got some indications on St. John's wort.
I just want to give a round of applause to Alexandra for speaking out.
Okay, let's please, guys. That's making her more anxious. I think, right, Alexandra? Okay. So keep in mind those herbal medications are used sometimes, as did say your doctor, because you can discontinue it abruptly and use it PRN. That's why she was prescribed that. Doctors are prescribing, non-pharmacological things, herbal medications, and those kind of, those preparations. Okay. Relaxation techniques, yoga, and meditation. It is huge, right? It is considered an integrative part of therapy. So we're not doing these things on our own, but they do help. Okay? It gets the mind to relax. It's, those kind of things, okay? Considerations across the lifespan, children. Anxiety is common in every age group, but the stressors and coping mechanisms are different depending on the patient's developmental level. In children, it's more prevalent in girls. Socioeconomic disadvantage are more prone to anxiety in children. Family disposition, again, genetics plays a role. There are risks for other mental disorders such as depression and substance use disorder, even children at a young age. Okay. The treatment is CBT, the SSRIs, acceptance and commitment therapy, which is they ask the child to review the unpleasant feelings, and then they try to teach them to learn new behaviors, not to be, in order to not be anxious and avoid the situations associated with the anxiety.
How young? I'm sorry, how young?
7 point, young, very young. Yeah, they can be on the SSRIs at a very young age. But dosing, you're thinking about dosing as far as children, always, right? And they'll also do some CBT, but it's dialectic therapy, okay? Dialectic behavioral therapy, that's talk therapy, okay? So they need to talk about it. It's a form of CBT, where you look at emotion regulation, reality testing, mindful awareness, meditation. It's like an off branch, but it's considered talk therapy. Okay? And you may see that in other age groups, but it is particularly helpful with children. Adolescents, huge group, right? What is the difference between someone who's an adolescent experiencing all those things that you experience as an adolescent, right? And having a problem with anxiety. It's very difficult to determine. Girls are more likely to be diagnosed than boys again. You want to also assess the patient for depression, developmental conditions, language problems, high-risk behaviors, and substance use disorder. Treatment of anxiety is similar to those to that with children. And the SSRIs, you want to be particularly mindful with adolescents because the SSRIs, right, when you first start them, the chances of suicidality are high. So you want to be very mindful with adolescents because that age group has, I think they're number 3 or number 2 as far as the cause of the suicidality in adolescents, right? It's a high. It's tough. It really is tough treating adolescents with an anxiety or depression disorder because of all of the things that they experience during this developmental age. What's that? Hormones, yeah, hormones too, brain development of the whole 9 yards. So it's a tough cookie to, it's hard. Okay, but be mindful of those SSRIs, please. Pregnant women, maternity anxiety leads to negative outcomes for mom and child, so you want to keep that in mind. There's problems with sleep, fatigue, panic, muscle tension. Birth defects are more likely in pregnant women that take the SSRIs, Prozac and Paxil. Those are the 2 big ones for pregnant people, okay? Pregnant women. The use of sertraline or Zoloft don't carry the same problems as Paxil and Prozac in pregnancy. The use of Zoloft in place of Prozac and Paxil is sometimes done because they don't carry the same you don't have the same side effects. Is that better?
Yeah, so you don't want to take Prozac and...
You don't want to be on Prozac or Paxil. That being said, you got to be careful to discontinuing medications when someone's pregnant and then taking meds for anxiety and depression, right? The SSRIs. Why?
Suicidal ideation.
Can be suicidal. All of the signs and symptoms when you're not taking the medications. So this is like between the doc and like the other person, right? Did you have the third trimester use looks like you're looking at pulmonary hypertension, newborn problems. Mild, that says mild anxiety, and that's correct, right? Because beforehand, you don't want to abruptly discontinue the SSRI. You want to taper it for several months prior. You never want to abruptly discontinue an SSRI. Okay? But you're thinking about pre-pregnancy when you're talking about tapering it off pre-pregnancy, if you're going to do that, if you're going to go that route. Some people who have severe anxiety and depression will decide to stay on their medication. And they're a high-risk pregnancy. Yes.
Well, and then the book says that the risks of those are only
the risk
1%.
Correct, and that's where you're going.
So it's really not.
It is. What's that? It's not as bad. So that's why it's risk versus benefit for pregnant women as far as their medications. But it's something to consider because those are major things. So that's why I'm talking about it.
So,
makes sense? Yes.
So for after, because I know with pregnancy after, hormones are up and down, they're really at risk for postpartum.
Postpartum depression.
Right. So does this being off the meds play a big part in increasing that?
It could.
Okay.
Yeah, if you're off your meds for depression or anxiety, it could absolutely increase the chances of postpartum. Yeah. So that's why people have to go. That's another good point that you bring up. People have to go back. Women have to go back on their medications.
Oh, nothing.
That's a really good point. I'm glad you brought that up. Because postpartum depression, you're better off taking your meds, and you're better off taking what SSRI? Zoloft. Thank you. Older adults. There's risk factors with older adults, right? There's cognitive impairment. There's lower education, if you have a lower educational level. If you have multiple chronic illnesses. Or you're unmarried. I don't know. I tell my husband this. Like, we're older adults. You're married. You're lucky. You're not going to run into anxiety, right? But being unmarried is a risk factor. You want to be mindful of the anti-anxiety medications because there's increased rate of absorption in an older adult. They take more meds, so there's a chance of increased drug-to-drug interactions. Again, with these medications, you start low and you go slow, especially with someone who's older, always with meds. And you want to be careful with the benzodiazepines because they can cause cognition changes in older adults. So your assessment, you want to do all of these things. To have good observation and patient interview. Take a look at the medical history to see if there's what's going on there, observe physical symptoms. Look at the family history. We know if there's a genetic component. Assess emotional and psychological well-being, social well-being, their socio-economic factors, home and work conditions, and a really good H&P, good physical assessment. So there's varying forms of anxiety, all right? So mild anxiety, you're going to have an increased sensory perception and arousal. You're alert. You are ready, right? Something's coming, you're ready to go, right? It can be helpful to focus in and concentrate. So you do want a little bit of anxiety going into a test. A little bit of anxiety is a good thing because you're so alert, right? You have increased alertness. That says sleepiness, but it is sleeplessness. So change that on your PowerPoint, please. You can't sleep because you're so, awake and alert. You're thinking about it. You have increased motivation. You might be restless or irritable. So for treatment, we really want to improve sleep. Look at relaxation and behavioral techniques. So that massage therapy, aromatherapy, all those kind of integrative therapies are really good for mild anxiety. They should help. Moderate anxiety, you have a narrow perceptual field. What does that mean? A narrow perceptual field.
Tunnel vision.
Tunnel vision. You are seeing what you're seeing. This you see your stressor and anything else that's going on the sides, it's tough, right? So you have tunnel vision. You're irritable, self-absorbed, you have increased restlessness, increased respiration, heart rate, perspiration, rapid speech, and it's loud. So that's really what the person was experiencing in that video,
How
right?
come it would be increased motivation? Would it be decreased motivation?
No, you're motivated.
Well, I might be motivated, but
With anxiety, you're motivated. You're absolutely motivated to take care of that tunnel vision. Yeah? So what kind of things would work here? What's that? Possibly medication for moderate. Distraction. Exercising maybe. Relaxation techniques. Integrative therapy. Low dose, you're talking about medications, you're low dose because it's moderate anxiety, right? You want to do some if you have moderate anxiety, CBT is a good thing because you want to identify those triggers that are making you feel so anxious and stressed. So cognitive behavioral therapy is a good thing.
So for moderate for the low dose meds, would you go to SSRI first, or would you do like a benzo, like those anti-attachment?
Benzos, if you can do it for a short period, if they think, we don't prescribe. But benzos, if you think that you can get it, taken care of in a shorter period of time than psychotherapy. We don't just do meds with this, ever, ever. There's always some kind of therapy once it gets moderate and then severe panic. Okay, that's a good question. And we always start low. We're really starting low with moderate anxiety. And not we, doctors, because they're prescribing, but that's what you're looking at as a nurse, okay? Good questions. Severe anxiety, this could be a problem. This is a potential for hospitalization with severe anxiety, okay? Your clinical manifestations are perceptual field that tunnel is very narrow. Difficulty following directions, you feel dread or horror, you need to relieve this anxiety, it's not going to, you have to take care of it. You might have headaches, dizziness, nausea, trembling, insomnia, palpitations here as well, tachycardia, diaphoresis, hyperventilation, and diarrhea maybe. Okay? So we are looking at the medications here. We're also looking at the relaxation techniques such as yoga, acupuncture, and massage therapy. CBT, absolutely. And again, the patient may need hospitalization at this point. It's all controlling. Clinical manifestations of panic are all written here. I'm not going to read it to you, but in addition, you're looking at the dilated pupils, immobility or hyperactivity, incoherent. They're not able to really understand any much. Okay? What's your treatment here? What are you concerned with panic or severe anxiety? What is your main concern when you have a patient that comes in? Safety. Cardiac as well, because you're going to rule them out for the physicals. Safety, how so?
So they don't hurt themselves.
You don't want them to hurt themselves. They cannot see, they cannot understand what's going on even in the room, right? They're all over the place. So how are we going to do that? What is absolutely necessary when someone's having a panic attack? Reduce the stimuli. What else? What's that? Let them know they're safe. They're panicking. They're really, right? Tell them they're in a safe environment. How are you going to do that? You're safe. Calm, cool, right? Calm, slow, very direct in your thought, in your verbiage, right? Nice and easy. Come on over here with me. We're going to take you to a room that's quieter. There's, explaining what you're doing. Tell them what's going on. Stay by their side. Don't leave them. Medication? Yeah. Absolutely. What kind of medication do you think we're giving here? Benzodiazepines. Okay? It's difficult. I think I have a video for you. The video for panic disorder, well, once we get to it, you'll see, it's difficult to see someone have a panic attack. It's difficult to see someone with severe anxiety, right? But we're the nurse and we know how to handle this. So your interventions are all listed here. I'm not going to read them to you. I'll just read a couple to you. Okay. For mild anxiety, try and have the patient visualize. We talked a little bit about interventions already. Importance of attending therapy, take your medications, and community resources. Moderate, you want to do some diversional activities to reduce stress. CBT is commonly prescribed. God bless. Relaxation techniques. Make sure they're adhering to their prescribed medications. Of low-dose anti-anxiety medications. Now, if they're not taking them, they are low-dose for the most part, but if they're not taking their medications, then what's the sense, right? They need to have them for a couple weeks for them to even be effective for the most part. And then the integrative therapies. Severe, we just talked about a little bit. I'm not I don't think I'm going to show you this video because you guys are almost ready for a break. You're tired of hearing me. It is online. Okay, it is on the PowerPoint. It's a man on a plane who's having a seriously severe anxiety attack, having almost panic, and it might be a little difficult to watch. So I'll have you do that on your own. But you want to be clear in your direction and ask them simple questions. You don't want to tax them too much. You want to identify some triggers yourself. You don't necessarily want to say to them, okay, what's your trigger? You want to identify the trigger and take it away, right, if you can, okay? If it's in the environment. Look at coping strategies that have worked, the medications, make sure they're adhering to therapy, and those integrated therapies once you're past the severe anxiety or panic attack.
Bless you.
Same thing here, God bless you. Same thing here as far as panic. In your evaluation, you're looking at new and improved coping skills. Can they moderate their anxiety when the stresses are present? Are they getting the sleep that they need, the exercise and nutrition? Are they back to baseline before the anxiety came on? Questions?
Yeah, for example, this is a reason specific with severe moderate anxiety.
Yes, I am. That was pretty straightforward, right? She said, for exam purposes, are you going to be specific? I don't know. Like, nothing's given. But I want you to know the different. Why is it so important to know the different levels of anxiety? How you're managing them, right? You guys come in on test day. I don't know. A few of my test people here. You guys come in on test day. I'm not worried about medicating you. I'm worried about taking it. No, I'm not. Because most of you don't have that extreme anxiety. You're able to concentrate. I'm worried, or not just me, all of us are worried about, I'll tell you a joke, do some deep breathing, do those kind of things that can get you out of your head, out of the anxiety, test anxiety, right? James is laughing because I told you a joke.
She's staring right at me.
What?
I said, she's staring right at me.
No, I'm not. You're smiling. You're in my room.
Do you have any tips on how to differentiate severe anxiety from panic? Because the manifestations are very similar.
They're pretty close. Panic is
more sudden and more like...
Panic is more sudden for the most part. Panic is like, it comes and it is all consuming. Severe, they have a little bit, you can guide them a little bit easier with severe. They're very close. Very close, you're right. And I'm not that tricky. I'm not going to say this is severe, right? Because they're so close. But you should know the difference between mild, moderate, and severe and panic. Any other questions? Because we got to take a break, and I want to get to that activity. I'm so excited today. Any other questions? Okay. You guys, if you have questions, I am checking the discussion board. I'm like, they don't have any questions for me. Put them up there, send them to me, okay? It's not close enough for the exam.
I need to run today. Go! Run! Oh. If you want. I don't know if I can see though. If you do it's like, how much do you need? No, take $4. Go buy some. If I don't get anything, I'll give you the bag. Thank you.
No. And if the word gets out, like, I know, but right, don't know what you want.
See, that's why I still
Can you hear me? Oh, you can hear me now. I'm sorry, next to my mouth. All right, so let's talk about obsessive compulsive disorder. So obsessive compulsive disorder is a disabling disorder characterized by thoughts and compulsive behaviors that dominate a person's life. There's obsession in it, which are recurrent thoughts. They're unwanted and distressing thoughts or images that lead to feelings of fear and anxiety. Compulsions are the repetitive behaviors, in addition to the obsessions. And the compulsions are used to mitigate or get rid of the obsessive thoughts and reduce the feelings of anxiety. To be diagnosed with OCD, the individual must be distressed and lose time more than an hour due to rituals and repetitive behaviors. That's part of the DSM-5 criteria. Okay? So it's a small amount of the population, of the U.S. population. It typically begins in adolescence and early adulthood. It affects men and women equally. So this is a little, there's an equal, it affects both. Men tend to develop it earlier. Your risk factors are, here we go with the genetics, again, a first degree relative with the disorder, history of childhood or sexual or physical abuse, and traumatic events, stressful events in childhood. Most of the mental illnesses are directly related back to traumatic events in early age periods in childhood, right? So that's why we talk about trauma-informed care when you're going into any mental institutions, okay? You want to be mindful of that. Howie Mandel suffers with OCD. You see him there with the gloves on while he doesn't touch anybody's hands. He wears gloves. He washes his hands a lot. So the clinical manifestations frequently reported obsessions, thoughts about contamination or shaking someone's hand, fear of hurting someone, leaving the door unlocked, needs everything to be in a certain order. The obsessions may be aggressive, religious, or sexual. The compulsions include hand washing, ordering, making sure things are in order, making sure everything's, checking, rechecking, keep checking on it, and counting. It doesn't produce any pleasure to be doing these things constantly for the amount of time that they're doing it. It just helps to relieve the anxiety associated with it. So the compulsions help to reduce the anxiety. Okay, let's see if this goes.
Michael Phelps has struggled through some dark times with his mental health.
You have to watch that.
What do you see there?
Wait, that was it?
No one.
No, I think you got enough of it. No? Yeah? So tell me, what did you see there as far as what it was showing? Counting.
Checking life.
Checking.
Hand
washing. Neatness.
But he didn't care when the gloves weren't all the way in the garbage.
Oh, okay, you have OCD. Notice that in the video?
I did
You might
notice
wanna
that
think
too.
about that, right? He probably did care. He was so, when you're doing your compulsions sometimes, like when you're doing the behavior, sometimes you miss those things. Like, that's a compulsion to have the gloves in the garbage, right? But he was concentrating on his other compulsions, which he does all the time. Making sure the number of soaps were there and those kind of things, right?
And I know
That's funny that you recognize that. I don't mean to point you out.
And I know sometimes it's very specific, like they can
It is very
hyperfixate
specific
on,
to
like,
what-
it could be a light and then they don't care about other things.
They
could
won't
be
care
very
about the other
certain.
things. It's very focused. You're absolutely right. Okay. So that was a pretty good example. That's an excellent movie. It's an excellent movie. And like, you know, I'm watching a movie about, it gets to the, as good as it gets.
Cut off that first.
Jackson. But that gives you a little idea of it, okay? So pharmacological therapy, here we go again. We do use the SSRIs, primarily Prozac, Zoloft, Luvox, and Paxil. The tricyclic antidepressants are effective. And then if need be, we will go to the antipsychotics, like risperidone. If the SSRIs don't work, the SSRIs are the go-to for obsessive compulsive disorder. Same kind of indications all the way through. You've seen this in the previous PowerPoint. Might want to know about SSRIs, okay? They do use cognitive behavioral therapy, desensitization therapy, careful exposure over a period of time to the object that promotes fear. Exposure and response prevention is gradual exposure to the objects of his or her obsession and fear. You teach healthy methods of how to cope with the associated anxiety. We're using CBT as well to restructure the thoughts. You are what you think. So you want to restructure your thoughts around the obsession and the compulsion. Okay? And if need be, they do use deep brain stimulation. Where else do they use deep brain stimulation? Last resort. Parkinson's disease, yeah. So they may use DBT if they're resistant to medication, okay? Lifespan considerations. Kids and adolescents think about disaster or loss. Their compulsions are similar to those of adults, like hand washing and those kind of things. They're more likely to experience rage attacks. And ERP therapy is first, and for more severe cases, we give the SSRIs. We are cautious with medications in children, right? That's why you start with your low doses if need be, okay? Older adults are less likely to discuss mental illness and fears, and they require a really good mental health assessment in order to get to an obsessive compulsive disorder. There's lack of diversity in research, as far as representation from Black and Hispanic groups. And you know this culturally, people of Hispanic orientation or descent, the population is less likely to receive treatment, especially for a mental illness. And that goes also with the Black population. They are not trusting, right? And there's some cultural stigmas in relationship to mental illness when it comes to those populations. There's the stigmas, the stigmas everywhere, trust me, right? As far as mental illness. But in these populations, it is more. We need some research. We really need to get more research as far as that goes.
It's funny because those are the populations that are most likely to have poverty.
Correct. The socioeconomic factors, as far as that goes, also play a role. So there needs to be some research here. The stigma stops mental health and illness research all the way. It stops funding. It stops a lot of things, right? Because people don't want to deal with it, but it is at an all-time high related to COVID, related to everything, right? So, if not us, who, right? We need to start thinking about some research projects, those kind of things as far as nursing goes, right? Lack of knowledge, educating your patients, absolutely. And there are some religious, as far as Catholic, Jewish, and Islamic faith, where there's repetitive or obsessive religious rituals that interfere with obligations. Okay, it's part of the religion. You have to do this at this time. Those kind of things. So you want to be mindful of that as well. So really, it's the same thing as a general anxiety. You want to get a really good observation and patient interview. Look at the current medications, their activity of daily living, and a really good physical examination. Those are your diagnoses. When planning, you want to look at things like triggers, how to reduce anxiety, the coping mechanisms for to reduce the need for those compulsive behaviors. Decrease time performing those is a goal, right? In planning, decreasing the time, because that's one of the DSM-5 criteria. Decrease how much they interfere with ADLs, and they need to participate in social activities. In that movie, he has a hard time. He does the same thing all the time, goes to the same restaurant all the time, right? So when there's a little bit of a change in his social activity, it's a little bit uncomfortable for him, but it is quite helpful in their obsession and compulsions usually. So we want to be non-judgmental, alleviate their fear, look for effective coping, effective role performance, and social integration. This is a tough one to crack, right? Because if you look at the evaluation, only 50% improve with treatment. 50% do improve with treatment, but only 10% will recover completely. So you still have those behaviors and obsessions, and only 10% will lose them all together. So you want to make sure you're doing frequent evaluations. Questions? What's that? Yes. They're repetitive. The question was people on the autism spectrum do have repetitive behaviors. Absolutely. Yep. What's that? Everybody is well aware that Professor Fish has autism spectrum. She talks about it openly, and he kind of does do those kind of things. He needs to be in certain places. He needs he's obsessed with, we're just relating this to autism, okay? He needs to know the street signs, he needs to go a certain way home, okay? He needs to count stuff. There's a lot of obsessive compulsive behaviors with autism, you know. So you want to be, I'm glad you brought that up, because you want to be mindful of the family. Someone who, like her, my heart went out to Helen Hunt in the movies, because, you know, they were developing a relationship, and it's just all consuming, right? It's all consuming to be thinking about that when someone has obsessive compulsive disorder, right? Checking everything, counting stuff, close the drawers, make sure you do all of those things, right? So just be mindful of the family. Always with everything that you do as far as a nurse, you need to be mindful of the family, because it's never just the patient. It's the family, right, for the most part. So you need to be mindful of the people who live with someone with an obsessive compulsive disorder. I would be exhausted. I compliment her daily, because it's tough, right? Okay, so any other questions, guys? Okay, so we're going to move over to post-traumatic stress disorder, again in the anxiety. Okay. So post-traumatic stress disorder, your readings are all there. These are your learning objectives, and again, your CCNP concept map for interrelated concepts. Okay. Post-traumatic stress disorder, it says recent events. 911 wasn't all that recent, but it was still a big event to be considered. Any war or conflict, particularly in the Middle East, but you know, now we're talking about different areas of the world, right? So those wars and conflicts, we want to be mindful of. Mass shootings, even recent events that with the Bristol police thing, a lot of people were affected by that. It's a post-traumatic stress issue, right? People can develop post-traumatic stress in relationships with all of these events. And then COVID-19, right? Clinical manifestations are flashbacks. They may lose touch with reality. They may cognitively return to the traumatic incident as if it's happening again. That's what a flashback is all about. And it was traumatic to begin with. Imagine going back again and again. It's not easy. Okay? Depersonalization is also emotional numbing. Difficulty with personal relationships, things they formerly enjoyed and no longer have pleasure. Uncharacteristically irritable, aggressive or violent, hyper-arousal or hyper-vigilant. You're on high alert. If you're having those flashbacks especially, you're on high alert. You're ready to go, right? I think as soldiers when I think about that, but anybody who is experiencing PTSD is usually on high alert, ready for the next trauma. They may have sleep problems, restlessness, agitation, difficulty with concentration. What's disassociation? What is it?
They're not with the reality of what's actually going on.
Correct. Yep. They're lack of continuity with their thoughts, right? They're more thinking about the flashbacks or the memories or what's actually, they're not really thinking about current events. Depression, alcohol use, and other substance use is common, and manifestations usually emerge within 3 months of the traumatic event, but can be ongoing, right? If a person doesn't seek therapy. This is a big deal. You really have to collaborate with everybody, kind of look at financial resources, social services, medical resources like free clinics, and mental health providers who treat the uninsured. Look at agencies for food and shelter. You got to take care of the basic needs. spiritual needs and leaders as well, okay? Because it's all encompassing, you're looking at all of these therapies necessary. Pharmacological therapy, I see the SSRIs again, all right? It's what's used basically for anxiety, okay? And depression, and again, those two are married. What's that? Prazosin you're using for those nightmares associated with PTSD. A lot of times with PTSD, they wake up at night terrors more than nightmares, right? So you want to use the prazosin or mini-press in order to treat those. All right. I just want to go back to because the SSRIs. The ones that we use primarily are Zoloft and Paxil for PTSD. SSRIs we've already spoke about. These are the side effects, the adverse effects. Okay. Non-pharmacological treatment, EMDR, eye movement desensitization and reprocessing. It's a psychotherapy which includes several. It's a form of CBT. It uses also dual action stimulus, and what they're doing is usually the patient closes their eyes. There's some tapping and toning going on, and you're kind of like thinking about something other than the traumatic experience, and we're kind of looking at what's going on there while we're doing all, like if you go online, you could see some examples of this. But what you close your eyes and you're kind of looking at relaxing. You're looking at also the traumatic event. Okay. Exposure therapy is gradually introducing the person to the traumatic event, either through journaling, pictures, maybe visiting the place even. You move up to visiting the place, okay? A lot of times they'll use virtual reality. And they talk about coping skills and the environment being controlled. It's no longer a traumatic event, the environment is controlled. Acupuncture may be effective and is sometimes used as well. That's an integrated therapy, not used on its own. Okay. Lifespan considerations with kids. I think 7.5 is the average. Under the age of, let's talk about under the age of 6. We want to use stuff like play therapy. You have the child drawing or acting out the trauma, painting, whatever. So, some puppets, some type of play therapy, because they can't really express their feelings at that age. They may display reckless or aggressive behaviors. At a very young age, you want to know mood changes. Are they going to bed at night? Are they forgetting how to talk? It's a regression. Usually you see regression symptoms. Are they acting out the events with other children? Are they exceptionally clinging or emotionally needing? All symptoms for a child. Adolescents, their clinical manifestations are closer to the adults. They may demonstrate disruptive, disrespectful, and destructive behaviors. May engage in traumatic reenactment where the traumatic events aren't there. They can inject them into their daily lives. They can be impulsive and aggressive. And again, you're looking for those like the telltale signs, right? Because teenagers are impulsive in general, okay? You want to look for increased risk of suicide, substance use, poor social support, and poor concentration. Academic problems is a big one as well, and poor physical health. Older adults are not limited to veterans, though we think of veterans when we talk about PTSD. Older veterans may have somatic complaints. Same thing as we were talking about with anxiety. An older person has more somatic complaints. What does that mean? What's that?
Physical manifestation.
Good. Veterans are a particular group that deal with PTSD. They are needing all of these types of therapies, right? And the complementary and integrative health as well. You want to make sure that they're getting the support that they need. All right? How do you do that for veterans? How do you do that for veterans? Yeah.
Getting the resources they need.
Yeah.
Take it out for mental health care and.
Correct. So that's why a lot of times on admission assessments, we say, are you a veteran? Because there's clinics, there's more out there. There should be even more. But you want to be mindful of that because they need all of these services, right? Dealing with PTSD post, being deployed or involved in activity.
They need to know that it's okay to talk about.
Exactly, because why is that so important?
The stigma.
The stigma, and you're talking about someone who went to defend the country, right? And might think that that's not, I'm a man or a woman.
They should,
There's women who are able as well, right? But a lot of times the stigma and the fact that they shouldn't need help is a problem. So you want to make sure you find out if someone's a veteran or not, especially when you're seeing signs and symptoms of PTSD. And make sure they get these services that they need. Thank you. When they are experiencing the aggressive and bizarre behavior, safety is huge, right? Make sure that for patients, but also for others, you want to quickly lower those anxiety levels. How are you going to do that? Pharmacological intervention. Make sure they're in a calm. This is the same as anxiety, but it's panic and severe anxiety. You want to make sure that this is happening. Tell them that they're safe. Okay? And make sure you don't forget about the families, please. Trauma-informed care. This is in your book, guys. This is important. And I really didn't stress it enough in the PowerPoint. Okay? It's in your book on page 2117. You need to know about trauma-informed care. I will post a video as well about trauma-informed care. It's very good. I don't know why I didn't have it up there for you already, but it's about someone who has dealt with trauma in the past and her role, Tony Ernest, her role in getting trauma-informed care more into mental health institutions and more out there nationally. So I'll post that for you. It's a longer video, but it's worth your time. Okay? But you want to know the principles of trauma-informed care, which are safety first, trustworthiness and transparency, peer support, collaboration and mutuality, like you have a common process. Mutuality is I'm not explaining that well, am I? Mutual, it's the same experiences. Okay? Empowerment, voice and choice, and you want to be mindful of the cultural, historical, and gender issues in trauma-informed care. If you have time, please watch the video that I'm going to post. It's empowering as far as PTSD.
Can you say those 10 things again, please?
I only have 6 from your book. Okay. This one has 10 in it, and you can't even read them, so that's why
they're on there.
What did you say?
I said safety. I'm going to repeat them. Trustworthiness and transparency, peer support, collaboration, mutuality, empowerment, voice, and choice, cultural, historical, and gender issues. It's in your book, I swear, on page 2117. Did you guys get them all? Yes. Okay. All right, questions about PTSD? I went through those last 2 ones pretty quickly. Questions about OCD or PTSD? No, don't go, please. We're going to do an activity, and I'm really excited. And there might be a prize at the end. Maybe, I don't know. They don't go.
Extra 5 points on your final.
So what I want you guys to do,
I'm excited.
and I'm excited because I was planning on putting up with, right, no prize for you. Okay, so what I want you guys to do, have you guys played heads up before any of you?
Yes.
Yes?
Yeah, or yeah. Like really. What is spider?
No?
No.
I'm going to divide you up into 6 groups. So this is the way I want to do it. 18, about 18, roughly 18 each. So you guys are going to come down over here, like as a group. Okay? This group right here is going to come down over here. Like you guys are split in the middle here, okay? This group is going to come down over here and work together. This group over here is going to come down over here and work together. There's a little bit more of you on this side, but that's okay. And then this group over here is going to come down here and work together. Okay? Oh my God, what? It's going to be fun. I promise. And listen, it's review of the past. It's a good review of the past 2 classes. It really is a good review amongst yourself of the past 2 classes. Whoever volunteers might get a prize to be the person who put the head thing on their head. What? James, I don't know. Maybe it might be something on
You've been
your
studying,
test.
right? You've been studying every day.
So,
You got this, right?
here's how it goes. One volunteer from each side.
I've been just
You're going to put this on your head, right? And you're going to pick
What
up.
is this headband? Oh God, no.
This is how the card is upside down. Okay?
Oh, okay.
The person
Wow, it's like that
who
game.
does this on your head puts the card into here. You guys in the audience need to explain what is on the card to the person who puts this on their head. Make sense?
Should we?
I think
But it's words.